Sir, your slides went off. Could you please put it on screen? 1
Okay.
minute to go live. We're about to start.
Hello.
Hello, sir.
କୁହନ୍ତୁ
Patient को लेके जाओगे
ଆସନ୍ତୁ।
ठीक है आज्ञा।
My screen is visible.
Yes, you can share your screen, sir. I told you we can start now. In another 1 minute, we'll start with the introduction and then we'll hand over to you. So you can share your screen.
Okay.
Yeah, so we are good to start, sir. It's sharp 7. With all your due permission, we are beginning with the session for today.
Okay. No. Anywhere. Nobody joined at all yet.
No, sir. Basically, they'll be looking from our portal. This will be getting directed to our portal. This is a Zoom platform where you and me are here, and the participants will be viewing it from our portal where they have registered.
Okay.
Okay, yeah. So to begin with, we are beginning with today's session. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent speaker for today's session. With great pleasure and honor, I would like to introduce a very renowned radiation oncologist, Dr. Kanucharan Patra, sir. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. Sir is the HOD at Radiation Oncology Brain Tumor Specialist at Mahatma Gandhi Cancer Hospital, Vishalchapatnam. Sir is MBBS and Gold Medalist, MD, DNB in Radiation Oncology. Sir is MBA, HA, FICRO, FAROI, USAI, CEPC, PDCR, Visiting Fellow Mannheim Cancer Center, Germany, Visiting Fellow Weill Cornell Medical College, New York, and ex-resident at Team MH Mumbai, and visiting trainee at AIMS, New Delhi. With the help of sir, we'll be taking a close look on today's topic on this day, which is World Brain Tumor Day, and the topic is glioma. Glioma is a broad term used to describe a group of tumors that originate from glial cells, which are the supportive cells of the central nervous system. These tumors can occur in various parts of the brain and spinal cord and can be either benign or malignant. Gliomas are the most common primary brain tumors, accounting for a significant proportion of brain tumor diagnosis. We'll be learning more about glioma on this occasion of World Brain Tumor Day, as observed on June 8th of every year. So now I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Good evening, all. Today is Brain Tumor Day. June 8th is the Brain Tumor Day, and today we will just discuss about the various types of brain tumor, what is the world is suffering. Let's for betterment of the brain tumor patients, we will have some we should know some things about the brain tumor. That is my motto today. As you know, cancer is the word everybody get frightened from doctors to patients. So we have to be very sensitively handle this cancer issues. And today is the World Brain Tumor Day, is observed on June 8th of every year to raise awareness, educate the people about the brain tumors. So what is the theme of this day? This day today, for the 23, though is a protect yourself, keep away from the stress. Chronic stress triggers sympathetic nervous system, neuroendocrine system that release stress hormones linked to increased tumor growth and developing the various ways. In addition, immune system also declines with stress. Therefore, the developing brain tumor adapting to daily stress management techniques limited to yoga, meditation, physical exercise can aid in the controlling stress, thereby helping the preventing the development of the brain tumor. If you the statistics you see, the brain tumor is one of the deadliest disorder affecting any gender, both adults and children. 90% of the tumors are the brain and due to brain tumors. It is estimated predicted tumor of the 2022 around 3 lakhs, and so this is end up around 3.7 per 1 lakh in men and 2.6 in 1 lakh per woman per year when adjusted for age. So when brain tumor patient comes to you, either family or doctor don't think alone. There should be population from the all people, either doctors or patients should work together. At last, we should think that patient should not have patient should not suffer either by lots of radiotherapy, lots of chemo, lots of surgery. So we have to go for the holistic approach and help them in the other way. So there is always a drop of hope. And the neuro-oncology team, it involves neurosurgery, radiation oncology, pediatric medical oncologist, adult medical oncologist, neurology, neuro-radiology, neuropathology, occupational therapy, physiotherapy, and clinical psychology. So just a look, 90% tumors are from the brain, and high grades are 38%, meningiomas and mesenchymal tumors are 27%. Other tumors are like pituitary, schwannomas, lymphomas, oligodendrogliomas, ependymomas, low-grade astrocytoma, medulloblastoma in decreasing order. Spinal tumors also sometimes it is there, schwannomas, meningiomas, and ependymomas. Why it happens? Mostly exposure to the chemical like vinyl chloride, Epstein-Barr virus infection, transplant patients where immune system is decreased, familial tumor syndromes, prior radiation, and poor mobile phones. We don't know if it mobile phones are going to happen brain tumors. We will get an epidemic of brain tumors so in future, but still it is in the clinical trial, and we cannot tell that mobile phones causes cancer. So there are familial syndromes like neurofibromatosis 1, 2, Von Apple disease, tuberous sclerosis, sleep paralysis syndrome, True-Cut syndrome, nevoid basal cell carcinoma syndrome, multiple enchondromasis. These are the various syndromes also associated with chromosomal abnormalities, and that causes brain tumor. So how they behave: raised ICT, pressure effect, deficits, other non-specific symptoms, seizures mostly 20%, other parenchymal tumors, and within more 70% of the primary tumors and 40% with metastatic tumors that develop seizure. So apart from the seizure, it depends upon the which lobe tumor is involved, either frontal lobe, temporal lobe, pituitary, brainstem, cerebellum, and all things. According to the thing, it will develop. So it may develop from astrocytes, oligodendrocyte, lymphocyte, meningeal cells, and primitive neuronal tumors. All sites can develop the brain tumors. So apart from that, we should go for a CT scan, MRI, MRS, contrast, perfusion scan, DTI, and PET scan has a very minimal role. We have to see the patient's tumor, whether which is located, size, contrast, edema, calcification, hemorrhage, extent, shift of the midline structures, intracranial herniation, CSF obstruction, hydrocephalus, and all things. So apart from that, we should go for the histopathology, immunohistochemistry, genetic chromosomal abnormality, intraoperative diagnosis by smear cytology, imprint cytology, cryostat sections. The various things are there. So apart from that, the various antibodies used for the ISC things, and sometimes we need some neuro-axis imaging. All brain and spine has to be screened, mostly in the medulloblastoma, peanuts, germ cell tumors, non-Hodgkin lymphoma, and pure germinomas. So you can see these medulloblastomas, they can spread to the spines, the neuro-axis site, and the surgery is the maximum. The best thing in the brain tumor is the maximum self resection. Either best thing is to go for the full resection or stereotactic biopsy if not possible. Histological diagnosis may be required in diffuse spontaneous gliomas, where proof of may not be required. And children's less than 3 years of age usually excised or biopsy should be done for optic pathway, hypothalamus, thalamus lesions. Initial chemotherapy is given less than 3 years of age, and mostly after 3 years people go for the radiation. Mostly it divides into grade 1, grade 2, grade 3, grade 4 tumors, but the classification has changed now. The grade 1 mostly pilocytic astrocytoma, SIGAs, they are very low grade tumors, and grade 2, grade 4 tumors like glioblastoma, these are very problematic tumors. So pediatric population, they go with medulloblastoma, atypical teratoid tumor, fourth ventricular ependymas, pilocytic astros, brainstem gliomas, peanuts. Young age, oligodendrogliomas, gangliogliomas, and peanuts. Adults, anaplastic oligos, GBM, primary CNS lymphomas, and metastatic lesions. Mostly female population go for the meningiomas, pituitary, and craniopharyngiomas are most common in the female population. Mode of presentation is the mostly low-grade glioma, small duration of headache, long duration of headache with acute presentation may be transform glioma, sudden headache, it is a high-grade glioma, spinal tumors, they may present spinal pain and peanuts with spinal mets. Site, mostly posterior fossa tumors are pilocytic, ependymomas, medulloblastomas, ATRTs, but gliomas, any site gliomas. Temporal lobe is the trainettes, ganglioglioma and ganglioneuroma. Surgery is the mainstay of the treatment. Open surgery or stereotactic biopsy, very extensive diffuse tumors or eloquent areas should go. Histological proof may not be required in the pontine gliomas and neurofibromatosis type associated tumors. So if you see only biopsy done patients have all patients, those are only biopsy, they survive less. And those we think, if you see the survival of the patients, if you see those are with proper near total excisions, they can survive long. So this is the, if you can see, those having more than 90% resection, they have a good, very good life. Those in less than 90% resection, having the survival is very less. So surgery should be any gross or total excision, but medulloblastoma we should avoid the BP-shunt. Surgical resection is definitely, even in stage 1, it is 100% stage, post-operative, stage 2 is the 78%, stage 3 it is 18%. Surgery is the mainstay of the treatment. Either may be total, near total, subtotal, partial, or biopsy. So mostly sometimes you use chemotherapy after surgery, mostly temozolomide, PCV chemo regimens, and children below 3 years we do use chemo, methotrexate, and CNS lymphomas. Role of radiotherapy in high-grade gliomas is adjuvant. In high-grade 2 gliomas, if there is a criteria, mostly low risk population, those are total resection less than 40 years age. We know IDS mutant, we no need to go for the radiation. But the unresectable residual low-grade gliomas require surgery. All brainstem gliomas requires radiation. Almost pediatric brain tumors require radiation. Spinal cord tumors require radiation. Metastatic brain tumors require radiation. Germ cell tumors require radiation. So those lesions are more than 6 centimeter. Astrocomponent deficits are there. Age is more than 40, and there is a midline shift. The radiation almost required. So what is radiation? Radiation is a part of the life. It is a the radiation discovery starts with the discovery of X-ray by William Röntgen. Now, after that, Marie Curie's radioactivity discovery, the radiation late at the end of the 19th century and early 20th century, the radiation treatment started. So in history with 3, see the Becquerel discovered radioactivity. 1898, Madame Curie and Marie Curie radium they discovered. Nobel Prize, they received a Nobel Prize. First successful of malignancy by basal cell carcinoma treated in 1903. So what happens? What is the radiation? Radiation is the high dose to the tumor tissue, normal tissue sparing, minimize the long and short-term toxicities, better quality of life. So how radiation is given? Delivered 5 days per week, 5 minutes, painless, no radioactive substance involved, side effects usually temporary and covered by Medicare population. So usually older days, this conventional methods where more side effects are there. Now the already multi-collimator is there, so that it decreases the dose to the normal structures. And if you see, these normal structures are getting less dose, and most the tumor tissue is getting more dose. And so there are various techniques like IMRT, IGRT, SRS, SRT, various techniques are there. So, and we use of MRI and CT fusion to proper describe of the tumor and properly delineation of the tumor. So if in older days, if you go for the radiation, we use multiple fields, and unnecessary, the normal brain gets more dose, But at the advent of new technologies like IMRT, VMART, and RPDR technique, we can give small the dose is confined to the tumor area, sparing the normal structures. So, as you know, most of the grade 1 tumors like pilocytic astrocytomas, they are things sometimes does not require radiation. Anaplastic astrocytoma, grade 2 gliomas, grade 4 gliomas, all these things require radiation. These are the various lesions. You can see this is the meningioma. This is the atypical meningioma from the meninges. This is the glioblastoma, high-grade tumor, mostly seen in the adult population. This is the oligodendroglioma, mostly you will find in the young population and more. Ependymoma, it may be third ventricle or fourth ventricle pediatric, third ventricle, the adult population. Craniopharyngiomas is the around the cellar area, you will get the craniopharyngiomas. Pituitary tumors in the pituitary area, and germ cell tumors you will get in the pineal area or supracellular area. Brain mets you will get anywhere. Gravoid junction you can get anywhere. And gliomatous cerebri is a different lesion where whole of the brain is multifocal lesion. Optic pathway gliomas, benign lesion. Optic pathway gliomas are the lesions mostly around the optic nerve. AVMs is the AV malformations, arteriovenous malformations. These are the things sometimes we can go with 7th, 8th nerves. So we can go for the radiation after surgery. Choroid plexus tumors also may be papilloma or carcinoma. These are ganglioglioma. These are the temporal lobe. Surgery is the mainstay, and sometimes you require adjuvant radiation. Sometimes spinal radius ependymomas. These are involved in the spinal lesions. These are the spinal cord tumors in the cervical spine. You can see these are the ependymomas, spinal epiminus. Then this is the spinal astrocytomas. You can see here the spinal cord tumors. So these are the various tumors, and one thing you have to see is the pediatric population. We have to give tender care. Mostly the pilocytic astrocytoma surgery is the most of the 100%. Most of the we can call it 100% cure. But if there is a residual, we can go for radiation. But pilocytic is a good tumor. And brainstem glioma, it is a grave disease, and patient hardly survival is 1 year. And this is the biopsy is not recommended. And we if possibly can take stereotactic biopsy. And so we have to give tender care and take care of the kids. Clinical presentation in kids is insidious cranial nerve palsy, long tract signs, cerebellar signs, long history prognosis, long history better prognosis. And the survival is very less in brainstem gliomas. You can see very 2-year survival is around 5%, and median survival 8.5 months. Ependymomas, again fourth ventricular ependymomas in the pediatric population. Atypical teratoid rhabdoid tumors, it is seen in below 2 years of age. It is very problematic, and patient will most of the highly malignant, and almost that is a sometimes it is near fatal. High grade hemispheric gliomas, it is very rare in the pediatric population. We sometimes we treat 4 neuroaxis, like from the cranium to till of the coccyx, all CSF spaces we have to treat. This is mostly seen to the peanuts, medulloblastomas. You can see this is the whole spine you have to treat, and this is the most things it is the needed in the craniospinal irradiation. It is very tricky, and this is the craniospinal irradiation. Whole spine you have to treat, and most of the pediatric population we have to take care about the normal structures, like starting from the thyroid to kidney to lung. And this is the how dose goes through the spine and the brain. And medical, sometimes the patient we cannot do anything like brain meds, or at the end of the disease we can give, that is dexamethasone, ranitidine, mannitol, and emetics and anticonvulsants we can use for the patients. And mostly we see the alopecia, dermatitis, vomiting, otitis, headache, seizures, fatigues that will happen. These are the common side effects of the radiation. And low grade gliomas we can follow for 3 months, then 6 monthly for 5 years. For the children with high grade tumors, high grade tumors and children, we can follow up at every 3 months. And the children who has received radiation, craniospinal radiation, we should go out, monitor growth, height, weight, endocrine function, and high-grade tumors we should go subsequent MRI imaging at 2 to 4 months. So in conclusion, teamwork, surgery is the mainstay, maximal safe resection, pathological review, ISC should be done. Radiation has a radical adjuvant role of chemotherapy is minimal. Timely reference from the people to the neurosurgeons and oncology is important. Low grade tumors when sometimes to observe, we should need the team discussion. This is the linear accelerator machine where we give radiation and most in the mainstay of the radiation treatment. Though I'm studying, discussing about the cancer, even stage 4 metastatic cancers where all organs are involved. So don't watch crying. You can give up any time. Even now, the stage 4 cancer, some patients are living 5 years, 10 years. So if there is a patient with brain mets, the metastasis would give a smiling death. Even there is a spinal cord mets is there. If you don't, the patient having paraparesis, if you don't give radiation, so even single radiation sufficient to prevent the paraparesis. Sometimes you go for the spinal fixation. Same thing, patient with multiple brain metastasis, you need to give whole brain radiotherapy. Patient will having throbbing headache, hemiplegia. Don't worry, we can give with whole brain radiotherapy. That is very important, and that can prevent the throbbing headache and hemiplegia. Even choroidal metastasis, you can see prevent that we can give it 10 radiations that will sufficient to prevent orbital ocular problems. Superscan or extensive bone mets. When there is extensive bone mets also, don't worry. In prostate carcinomas or breast carcinoma, people will live 5 years or 10 years long within this disease. So don't worry. Prophylactic radiation, when we give the prophylactic radiation, sometimes there is osteolytic lesion. To prevent the fracture, we give prophylactic radiation. Supravenacaval obstruction, we can give radiation for the prevent the supravenacaval obstruction. So that may mostly lung and breast cancers. So what are the cautionary signs of the cancer? Change in bowel habit, change in bladder habits, bleeding from a sore that does not heal, unusual bleeding or discharge, thickening or lump any part of the body, difficulty in swallowing, changes in the mole like color, size, bleeding, nagging cough for a long time, and all these things we have to keep in mind, and we can take help of a doctor when there is these all symptoms may cause cancer. So be aware, but this person is still not aware. And as you know, alcohol causes 7 cancers in the many cancers in the body. Non-vegetarian, excess non-vegetarian causes mostly colorectal malignancies, and smoking causes lung cancer and many more cancers. So smoking in a closed space causes more malignancy chances high. Don't start at your home, and these things don't influence your kids to go for the bad things. We should obesity causes 7 cancers in the body, so we should go for the cycling, walking, and smoking, physical inactivity, bad eating habits that causes lung cancer, lung disease, cancer, diabetes, heart disease, obesity. So we have to work hard. Passive smoking we should prevent. There are 2 vaccines we can take. One is the liver cancer vaccine, hepatitis B vaccine, and Gardasil for the cervix cancer vaccine. That liver cancer hepatitis B vaccine hardly 150 rupees total dose. It can prevent hepatitis B induced malignancy. Cervix cancer vaccine, it should give 3 doses. It can prevent cervix cancer in the patients. So stop drinking alcohol, relax, do meditation, take more dietary fruits and vegetables, and breastfeeding is the best thing to prevent breast cancer. Regular checkups, do the physical activity, do yogas, and do stretchings wherever you want, decrease the obesity. And as you know, previously most of the required lots of blood required for the malignancy treatments, chemotherapy. Now the filgrastim is there, so that will help to prevent the neutropenias. You can use chemopores to prevent the peripheral skin problems. There are many drugs are there we can use orally, and cancer is so much treatment is so much advanced. So you can use various forms of tablet forms. So finding a cancer hospital under one roof, all specialists should be there, and there are brave celebrities who fought cancer. And this is the machine where we treat radiation with radiation. Just do it, but doing it is not enough. What to do is very important. And as you know, the Gandhiji's three monkeys: don't talk, don't listen, and don't see. But this is a different monkey, where you have to take second opinion. You have to talk to people. You have to listen and do whatever you want to do, and research on cancer and propagate the knowledge to everybody. So we have to work together with your every people. Then this will be the fine, and we will be in the beautiful world. So thank you very much. Thank you, teachers, and dedicated to my patients. Today is the brain tumor day. Yeah, here I am completing my talk. Thank you very much. If any questions, you can ask.
Thank you so much, sir. Thank you for such wonderful inputs upon the topic that you have shared today. We have received few questions from the participants. With all your due permission, I would like to put it across to you. Hello.
Yes, ma'am. Yes, you can ask.
The first question is, which genetic tumor markers have been used to classify glioblastoma multiforme?
So see, there are lots of things are there. It not a single genetic marker that classify glioblastoma multiforme, but the thing many markers are there. So it is not a single thing, but it is mostly IDH wild types. They behave like the glioblastoma, and many more things are there. It is a long topic. We can talk in the next talk.
Thank you so much, sir. We'll move to the next question that we have received. And the question is, what is the reason for different appearance of glioma tumors on T1 pre-contrast MRIs? What is the reason for different appearance of glioma tumors on T1 pre-contrast MRIs?
So most of the low-grade gliomas, they don't enhance, but high-grade gliomas, they enhance. So more for low-grade gliomas, T1, because of the activity, cellular activity or necrosis, the high-grade gliomas, they have necrosis, they will take more contrast, and it will be clear boundary. But low-grade gliomas, they don't enhance. High-grade gliomas, they enhance.
Thank you so much, sir, for answering this question. We'll move to the next question. And the next question is surgery the only possible treatment for primary brain tumor, or is there anything else that you would like to suggest?
So most of the tumors, not all tumors, most of the brain tumors, they require surgery. Surgery is the mainstay, and at least stereotactic biopsy is mandatory. If not possible, not a very eloquent location, we cannot do surgery when there will be deficit come, but surgery is the mainstay. But after that, you may require radiation or chemotherapy as per the tumor.
Thank you so much, sir, for answering this question. We'll move to the next question and the last question for today's session. And the question is, which conditions should be considered in the differential diagnosis of GBM?
So most of okay. So glioblastoma multiforme, most of the tumors sometimes high grade. The most common differential diagnosis are confusing things when you take the MRI, metastatic lesions, abscess, and the glioblastoma, all things there. So only seeing the MRI, a single T1 contrast or something, we cannot tell. We can do for the some various scans like MRIs, perfusion, and all things. So differential mostly either a single lesion mostly goes in the favor of glioblastoma, multiple lesions goes to the favor of metastatic lesions. So it is again a big class. If anytime permits, I will go through details.
Thank you so much, sir. Thank you for answering all the questions. That was the last question for today's session. And with this, I would also like to thank all the viewers who had joined our platform and who were here with us throughout the session for listening to your wonderful talk. We hope that your talk will definitely help them in their daily clinical practices. So thank you so much for that, sir. And with all your last comments, sir, we can conclude the session here for today.
Thank you, ma'am.
Thank you.